We can go to the next speaker. I'll just have a quick look. Of course, I want to introduce Professor van de Wyngaert again for his second lecture on how to use bone scintigraphy in knee osteoarthritis.
Okay, thank you, Stephen, for the introduction. And the scene has indeed been set, but we will be switching gears a little bit and moving back to imaging from a knee osteoarthritis point of view. So I took the liberty of interpreting this title in a broad way. That is, I really want to focus on where I believe bone spec CT of the knee is going, rather than detailing where we are today. But again, I have to start with defining a place or a niche of bone scintigraphy within the area of MRI. And then I will review with you the very recent evidence on bone spec CT of the knee for osteochondral lesions, compartment loading, and recurrent pain after TKA. And that is possibly the most important progress we have made is in that area. And to conclude, some thoughts about cost effectiveness. So you've seen this slide before this morning. Again, if we are talking about bone scan in knee, then we are talking about fully integrated SPECT-CT hybrid multimodality imaging. So what is the role of bone scintigraphy in the era of MRI? Also, as I said, for the knee, for the ankle and the foot, MRI is a very powerful tool for assessing the painful knee. It gives you exquisite detail of ligaments, menisci, synovia, and so on. However, we do know that there is an issue with image degradation for bimetallic implants despite use of mass, and there is a limited assessment of cortical bone. And that is possibly or probably the niche for bone spec CT can be of assistance to you because it is not hampered by these artifacts and it allows an easy way to look at cortical bone. Another common misconception or confusion in the literature exists about bone marrow edema on MRI being the same as uptake on bone scintigraphy. However, I do not believe that is the case. There is definitely overlap, but there is data showing that both actually visualize distinct biological processes. And that was shown in a study in patients with chronic medial knee pain and where bone scintigraphy was compared with MRI. And all patients had non-traumatic chronial medial knee pain. And when looking at the sensitivity to predict or identify in patients who were symptomatic during exercise, you do see that uptake on scintigraphy was better at identifying these patients compared to bone marrow edema on MRI. So uptake on scintigraphy was more sensitive in this study compared to bone marrow edema and to detect mechanical bone overload, and do show that both give you separate information and both cannot be interchanged by one another. Now, we have been looking at bone scans most of the time in a qualitative way, but we are moving ever further in semi-quantitative and quantitative direction as other imaging techniques as well. So that means that we are calculating numbers, we are calculating ratios and looking how that can ease or give us more detail than just simply looking to it in a qualitative way. So in this paper, which looked at the assessment of osteochondral lesions and compared SPECT-CT with MRI, it was done in a semi-quantitative fashion, so ratios were calculated and higher uptake or relative uptake was seen in high-grade lesions and larger size lesions. Cutoffs were suggested in this paper, but I did not put them on the slide because that will require further validation before we can use them. But the authors did suggest that it did help them in stratifying their patients complementary with the information from MRI towards just an osteochondral repair or a chondral repair. So there is potential value in getting more out of your data set by doing these semi-quantitative measurements to select patients for an optimal treatment in this setting. And with the very newest SPECT-CT devices, you can really go even further and go to fully quantitative assessment. So it gives you an absolute value of bone turnover or tracer uptake, which is a substitute for that. And this was shown in a proof of concept study, again in patients with medial compartment knee osteoarthritis. And their SPECT-CT SUV, which is how we call this uptake value, was compared with visual assessment on MRI. Interestingly, or what you could expect, is that there was a high level of concordance of SUV with what you see on MRI, but SUV was simply much easier to measure. So this may help you in doing this more quickly. It can also reduce subjective assessment and issues with reproducibility. And it can assist you in a very easy way to determine what is possibly the clinical relevance of the lesions that you can find on MRI. So this is very interesting research that is ongoing at this time. And that brings us to the next big issue in bone scintigraphy of the knee, and that is the recognition that the biomechanics of knee loading is really crucial to understand what you are seeing on SPECT-CT. So we are realizing more and more that we need to take into account the biomechanics when we are reading these reports. And the basis for this finding was laid down a few years ago in this paper, showing that patients who had higher levels of uptake on bone scan did actually translate very well, or could be explained by the biomechanics of these knees, whether they were in valgus or varus alignments, and that correlated with the level of degenerative disease that was seen on X-ray. So bone SPECT-CT for the knee is probably a sensitive 3D method to localize mechanical overload to the affected compartment, and it hence can be used as a biomarker for knee loading. So that has translated into specific acquisition protocols that we can program on our devices by including some hallmarks or reference points, and hence do calculation of the biomechanics of the knee, how is the knee positioned, and then see whether these, we can explain what we see on bone scan as physiological because of the biomechanics of the knee, or vice versa, identifying what really is pathological for an expected particular biomechanic situation. So, as I told you, I do believe that in particular for assessment of painful total knee arthroplasty, bone SPECT-CT can be useful. And if you simply look at the reasons why revision surgery of these arthroplasties is performed, you see there's a multitude of causes that can be found, but interestingly they are spread right across the board, so you really have to take them all into account as a possible cause for the patient's problems. Some selected evidence I've summarized for you in this table shows us that compared to SPECT-only imaging, bone SPECT-CT really is more sensitive and more specific, so that will not be a surprise. So it's definitely of value or the way to go, or the state of the art in bone scan today. But what was also interesting is that two separate series demonstrated that if you use it in the painful TKA setting, you do see an influence or an impact on management in approximately 85% of patients, and that is of course huge. The task then for us as nuclear medicine physicians and radiologists as we do these studies is to stratify patients in what we deem to be surgical causes of recurrent knee pain after TKA, and those that we would consider not to be surgical causes, because that is of course what the referring physician wants to know. And broadly, these are the categories that we use. With the exception of malposition and instability, as these do not always require these advanced imaging techniques to come to this conclusion. Plain X-ray and physical examination will probably help you very much already. So an example of how linking bone biomechanics with bone turnover can provide additional information. So shown here is the SPECT-CT study, which probably would just be read as positive for patellofemoral problems if we do not consider the biomechanics any further. But with the help of these tools, we can see that other things are going on. So there's an internally rotated femoral component, which basically gives you the cause why this patellofemoral problem was caused in the first place. So you can dig deeper if you incorporate these data within when you are reading these studies. But that, of course, requires training and experience and standardization. So we are probably not using this as much as we should do, but it has, the data is out there, it has been published, that if you use standardized ways of reporting bone scintigraphy of these uptake places, as you illustrated on this slide, you can actually come to a table of uptake patterns that you can combine and explain by what is physiological or what is a pathological pattern of uptake given that specific biomechanic situation of that knee arthroplasty. So that is something that we need to propagate within the clinical field, because I do believe it will make our reports much more specific than they probably are today. But don't throw out planar scintigraphy as yet. Don't forget, we do blood pool imaging on planar scans still. And sometimes SPECT-CT can show you really nothing special, but it are the blood pool images that give you the diagnosis, which would be synovitis in this patient, which is, of course, a transient thing on bone scintigraphy. You only see it on the early imaging. You do not see it on SPECT-CT late phase images. So that's why we are now taking this one step further, because, of course, if you do SPECT-CT in the late phase, you have this wonderful, complicated 3D anatomic data set, but you kind of tend to lose your 3D or your third dimension when you need to compare this with your planar blood pool image. So that's why we now have implemented in our daily practice a clinical protocol of blood pool SPECT imaging followed by late phase blood pool SPECT-CT. And thanks to some fancy computer techniques, we can fuse these with the same data set, so there's no additional radiation burden for the patient. But it gives you a good correlation of what you would see on late phase as increased uptake, which actually correlates with active inflammation as well. So that is a wonderful thing that we can now do. Just some samples to give you an idea of the images that we create. So obviously this is too much uptake on these sides here, there, and there. So yes, this would be a loosened prosthesis. And then in the last minute, I have just some costs and cost efficiency thoughts. So new techniques are wonderful, but they're most of the time very costly. So is it worth paying for them? So we have been working recently on a cost-effectiveness model. It was based on an American, on the US pays perspective, simply because Medicare, Medicaid is much more standardized than the European healthcare systems. But what was interesting, if you would position SPECT-CT against just regular CT or mass MRI, we could show that bone SPECT-CT in fact saved you money in the post-TKA setting, but also that it was associated with a gain in quality-adjusted life years, so your patients do better. So really, this technique has the potential to become a dominant strategy in the workup of TKA. So to conclude, bone SPECT-CT is definitely the new standard for assessing, for the scintigraphic assessment of the knee. So if you do bone scintigraphy for a knee, demand that a SPECT-CT is done. It can help you to assess osteochondral lesions, to determine compartment loading, to differentiate surgical from non-surgical causes of recurrent pain, and it may save us all costs and improve outcome of your patient. And the validation of these semi-quantitative and quantitative assessments is currently ongoing. I thank you for your attention.